Okay, good morning all. Welcome to our Infection Prevention Control webinar presented by Chris Patridge, obviously for NASHICS, National Association for Safety and Health in Care Services, as I'm sure you're all aware. Chris is the Infection Prevention Control Deputy Clinical Director for Infection Prevention Solutions. This webinar will be approximately 30 to 45 minutes long. There will be opportunity to ask questions, of course. There are a couple of opportunities actually. So firstly, you will be able to ask questions within the chat. You'll also be able to ask questions at the end. And we also suggest that if you need clarity of any of the information that Chris gives us, please feel free to raise your hand, which you'll find at the bottom of the screen. And once you've raised your hand, once I've spotted that, I will let Chris know and we'll stop the presentation per se and ask that question. Obviously, we are recording this session. As I've said, it will be made available after the presentation, but not immediately afterwards. And the presentation itself will also be available. So without further ado, I'll introduce Chris. As I say, Chris is the Infection Prevention Solutions Deputy Clinical Director. She was a critical care nurse and now since 1997 was working within infection prevention control. Hopefully I'm getting all of this information correct, Chris, so feel free to correct me if I get it wrong. She was a specialist clinical lead for the COVID incident response team and then retired from the NHS and now works back part-time with Infection Prevention Solutions and has had an array of experience and expertise in the health and social care sector. So without further ado, I will hand over to Chris, who will present today's webinar. Hope you all enjoy. Chris.
Thank you. Just bear with me while I do what I need to do. Share screen. That one. Share. I love it when things work when I didn't really expect them. Go back to slide one, and there we go. So I hope you can all see that. That's not going to be the first query that I get. So hello, it's lovely to be with you and sharing a bit of space, albeit virtual space. And I look forward to our conversations later on. As Brett said, yes, I've been an infection control nurse for what feels like forever. I kept trying to leave it in my role in the NHS, but things kept happening like big outbreaks and then COVID. So I had to kind of give in and stay with it. Just a couple of other things to say before I move the slide on. First of all, possibly apologies in advance. I have two little dogs here with me. This is a very small cottage and it's open plan, so I can't put them anywhere. So I very much hope they will stay asleep as they are now, but if they do bark, then my apologies. And secondly, also potential interruption is I am 12 days into a rather heavy cold and the cough suddenly can appear. So little silent prayer, no cough, no dog barking, and we'll be fine. So this is not an infection control training session. I will not be showing you videos of how to wash your hands. I'm sure you'd like to hear that. I want to look more about how we manage care homes or how we can manage infection control, particularly in care homes, but in social care settings more broadly. And that is how we're going to walk through this over the next 20 to 30 minutes. With a bit of scene setting, what governance looks like, what we might have in place, how we cover off the operational angles and the staff. And then I think possibly the more important part of this webinar is the last bullet point, is your chance to come to me and share your challenges, your questions, things that keep you awake at night. And also share some of the, I'm sure you have done this, some very innovative solutions to problems. As Brett said, if you've got questions as we go, pop them in the chat. But if there's something I haven't explained, then please do raise a hand and Brett will interrupt me. So we'll start with the definitions because we have to have the definitions. And these can be found in many publications both from the NHS and from CQC, and I think they're in some of your own documentation as well. And it is about risk management, and I always start talks like this with this very important point. We all want everybody affected by whatever it is we're doing to be safe. That's what it's all about. But the fact is, we can't prevent every single infection, just as you can't prevent every single fall in the home. And so we're about mitigating the risks, about identifying what the risks are and then mitigating against them. And when something does happen, then having a very open approach to investigation so that we can learn. As providers of social care, just as all providers of healthcare, you are regulated by the Care Quality Commission. And they do their inspections, and you know this better than I probably, using these 5 key lines of inquiry, or domains as they call them. Generally speaking, they pop all infection control related comments into the safe domain. But I think you can easily see that the effective, caring, responsive and well led would also be relevant. If leadership is poor, there will not be good infection control. If staff aren't caring in their approach, then there won't be good infection control. But the reality is, when it comes to their reports, they focus very much on the safe. And one of the difficulties sometimes in doing this is that infection control is not the only risk faced by your organisations, by your service users, by your staff. There are others, and sometimes those risks can clash a little bit. Back in 2007, we had, then it wasn't CQC, it was the Healthcare Commission, and you had for health, and you had social C-Sky, wasn't it? And the Healthcare Commission started doing focused infection control inspections of hospitals. And they were a big problem because they only looked at infection control, they didn't look at any other risk, and therefore they took it out of context. CQC have on a number of occasions spoken about maybe doing that themselves, and I hope they don't, because it does create that difficulty of how do you prioritise one risk over the others. The classic example that illustrates this is carpets. As an infection control nurse, I'm not very fond of carpets, but you know better than I how slippy an uncarpeted floor can be, and thus raises risk, increases risk of falls in a vulnerable population. So again, let's remember this is about risk, and this is and that includes balancing the different risks that you face. So the prompts, the questions that CQC have written to support this aspect of their inspection visit is what arrangements have you got? We'll come back and talk about that in relation to governance. Always a big emphasis on cleaning and hygiene. Secondly, about staff, what do they do? How do they know what to do? Do you know that they're doing what they should be doing? And also how you communicate with other organisations where that relationship may impact on the health and safety of people, either your service users or your staff, or the staff and service users in another organisation. So that's the kind of framework that they're looking at. The questions, they're gloriously broad, and that means they can look at pretty much everything, as you know better than I do. The Code of Practice has become for us in the last 10 years a bit of a Bible since it was first issued in 2008, last revised in 2015, and this lists the 10 criteria with which you must comply. 2 points to talk about as far as the code's concerned. First of all, it's not a legal requirement that this is followed. But if you should choose not to follow it, then you must be able to demonstrate to CQC and to your commissioners that you're doing something else that ticks the same boxes. So generally speaking, people have made the decision that it's just simpler to try and implement and follow the code of practice. The second point is it has just or is being revised again. It's in its last consultation and will be published, we are told, before the end of the year. I have seen the current version of the draft that went out to consultation. The 10 criteria have not changed. There are just some better clarification elements of the overall document. I haven't brought it with me and I'm not sharing it because it is still at consultation stage. But I think my best advice to you is to get in touch with your local relationship advisor, locality manager, whatever the titles are in CQC, and just make sure that you are going to receive a copy of this when it is published. We know in infection prevention solutions how difficult it can be sometimes to keep up to date with guidance. This one is so important to you that I think it's worth going and asking and saying, you will let me know, won't you please, when it is issued. Scheduled at the end of this month. These are, well, they were, bear with me, my finger just had a wobble. These are the 10 criteria within the code that apply to a lesser or greater extent to nearly all providers. So what are the management systems? How does that work? How do you control, and that's that important word, that control, infection within your setting? A big chunk around the environment and equipment and hygiene, which is just ever increasing in importance, frankly, and I'm sure we'll come to that in the discussion. Antibiotic use is of very limited relevance to most of you probably, because you don't prescribe, but it is recommended that you have a good understanding of the challenges that overuse of antibiotics give us. Information on infections and how that's shared with people who need it, how infections are identified and managed. Big chunk on staff, I mean, they're number 6, but they should be number 1 really. Isolation facilities and what you've got and how you use it. Laboratory support is not relevant, I think, to pretty much all social care settings because you don't yourselves use a laboratory. The GPs do, district nurses do, but you don't. Policies and procedures and which ones you should have, and then the second part around staff, which is occupational health and provision of suitable occupational health advice and guidance. So that's the scene setting chunk. Let's move on now to what do we mean by infection prevention and control governance. This is how you will demonstrate to everybody who needs to know, CQC and your commissioners, but also your service users and families want to be assured about this, that you are, again, it's my favourite word, control. You know what's going on and you're mitigating these risks as they appear. So it starts, of course, with policies. The code of practice lists which policies you have to have for your people. And then it's a question of how do they access the policies? And I'll come back to that a bit later. So you've got the policies. The next question has to be, are they being implemented? And how do you know they're being implemented? And this is where audit and monitoring become so important. How you report stuff around infection control is the next point. It may simply be, if you're a very small organisation, there may be a quarterly meeting that gets minuted and that's it, and that's fine. If you're a bigger organisation or you're part of a bigger multi-site organisation, then there will probably be written reports that go up through your organisation on a regular basis. It's essential that these reports, these descriptions of what's happening in the world of infection control, are shared at the highest level in the organisation. So those who are ultimately accountable are kept abreast of what's going on and can therefore respond and make risk-based decisions. You also have to report outside your organisation. There are certain things, you know what they are, have to go into CQC. You may well have a requirement for reporting into commissioners, into local authorities, into CHC teams, children's continuing care. And those reports should mirror, obviously, what is reported internally. And then there is what I loosely call public-facing reporting. Particularly after COVID, there is generally at large in society quite a lot of concern about infection control in social care. And I think it's helpful to you, as well as important to the public, to share what you're doing, to show that actually you are on top of it, you are doing stuff, and that will ease perhaps some of this anxiety. Moving on then to the kind of headings, if you like, that we look at with reporting and with planning an infection control programme, that's how care is delivered, how hands-on care is delivered. What's the environment like? The environment can be helpful and can also hinder. And I don't know you guys, I don't know where you're working, but from my own experience of supporting particularly care homes, and I'll start with care homes, some of you have kinder environments than others. Some homes were built a long time ago, long before we worried about infection control. And you have to adapt what you're doing to A, identify the risk, and B, deal with those risks. If you're in a domiciliary care setting, of course, you have pretty much almost no control over the environment at all. So then it becomes, how do you manage that? If you're going in 4 times a day to care for somebody and their house is not as clean as you would like it to be, how are you going to manage that risk? Equipment, again, is a hygiene issue as far as infection control is concerned, but you will also have other potential health and safety risks to deal with equipment, hoists, for example. And lastly, managing infections, which you'll recall was one of the one of the criteria in the codes of practice. How do you recognise that somebody's got an infection, and how is it then managed? In terms of clinical care, that's usually down to the GP or possibly the district nurses. But in terms of how you manage the prevention of spread of the infection, that is down to the organisation. So the last slide in this webinar is about staff, but staff are not an also-ran, are not an end-of-the-road thought. Without staff, nothing is going to work. Infection control is not going to work if staff are not engaged with it. So there's a number of subjects to think about with staff. What I haven't put here is the numbers of staff. And there was a piece on the BBC this morning about the care sector hemorrhaging staff at a higher rate than ever before. And that certainly in and of itself produces risk. If you haven't got enough people, that's a real problem. But aside from that, the first and most important thing is training, that people know from the moment they start to work with you what is expected of them, what the policies are, what the procedures are, and that training is then refreshed on a regular basis. Most people go for 1 to 2 years, but that is a decision for your organisation to make, possibly in discussion with CQC. There is nothing written anywhere that says it must be 1 yearly or 2 yearly. Second point is around uniform or clothing. Most of your staff probably do wear a carer uniform. In some settings that's not advisable, but whatever the clothing is, how is that managed to ensure that you've mitigated the risk of picking up microorganisms onto a tunic from one resident, and taking it to another? Staff need to be supported to do what we need them to do. And this brings me to something that is a bit of a bee in a bonnet for me, and that's this word audit. I mentioned earlier on that seeking assurance that people are doing what they should be doing is a very important part of an infection control program. But people can feel very threatened by audit. It is felt to be a test. I'm being measured and I might fail. Whereas what we really want with audit, the culture we really want around audit, is that it is an opportunity for me to get even better. So to identify when I'm not doing it quite right, and then think about why am I not doing it quite right, and helping me put it right. And it is that culture, and if we can't change that culture, then we won't get the most out of audit. I have had success in the past with changing the language and talking about monitoring rather than audit, and also engaging staff in the whole audit process or monitoring process. Get their help in writing the questions. Make sure that they have the opportunity to tease out for themselves where they think it's going wrong. We know in health from a number of years now and huge numbers of investigations of incidents of all sorts, that it's very, very, very rarely that staff are culpable when things go wrong. Usually the framework in which they're working, the equipment they're working with, the pressure they're working with, leads them to do the thing that caused the problem. And I have little doubt it's the same in care home. If there aren't enough staff on duty at any one given moment, then hand washing will not be up to scratch. You don't need to be a specialist nurse to work that one out. So that's why I've put this under the word support, because it's very, very important. And I'd be really glad if some of you can come up with some things that you've done around this, to help people feel comfortable with audit and use audit in a positive way. The next point is about access to guidance. And I mentioned this a little bit earlier on. You have policies, you may have protocols, cleaning schedules, all sorts of documents. But are they accessible to staff 24/7 is my question for you to ask yourselves. In healthcare, generally speaking, these are all now held electronically, because most staff working in a hospital setting have fairly easy access to a computer or laptop. And that may not be the case in your setting, in which case, where are they? Where are the policies? Are they available on a Sunday afternoon or at 2 o'clock in the morning, which in my experience is when we mostly need access to them. Some homes I've worked with in the past have come up with much smaller documents that pray see what's in the policy, which can be made more readily available. Perhaps we can pick that up in discussion as well. And then the final bullet point on this slide is around occupational health. Again, if I look at hospitals, it's easy. They have an occupational health department. It's there all of the time. But you don't, and you don't want to, and you don't need to. But you do need to have some access to occupational health. When staff join you, there needs to be a consideration of their health, of their vaccination history. There needs to be support for key vaccinations like flu and the COVID boosters that we're currently going through. You may have arrangements with the local GP who looks after most of your residents if you're in a care home. You may direct staff to their own GP, but there has to be some provision here. And also, you need to be able to access occupational health if you do have a transmission incident that you're going to need some help with staff. And as an example to illustrate that, I was involved a few years ago in a very large outbreak of group A streptococcus infections in chronic wounds in older people in the community, some of whom, not all, were in care homes. And we needed to swab staff, and we needed to get antibiotics to some staff. And so that there had to be some way we could source that occupational health support for our care homes, as well as the health staff. So that's the really important slide about staff. And as I say, I'd be really glad if we can have a bit of a discussion on that going forward. So that's the end of the formal part of the webinar. And as I've said, and will continue to say, I very much hope that the next bit gives you even more good ideas and thoughts. So it's over to you. Questions, things that worry you, things that give you, as I said, sleepless nights, challenges, of which there are many, but how does this impact on infection control? And yes, please do share innovative solutions that you've come up with. Thank you. I'm going to stop sharing so that we can all see each other properly. There.
Thank you, Chris. That was really helpful. So I guess it's kind of handing over to our attendees. As Chris said, do you have any questions? Would you like to discuss any challenges or ideas, innovation around what you've heard today, and equally around infection prevention and control within your own organisations and your experiences? Very quiet. Obviously, if you do have any questions, feel free to unmute yourselves, and you're welcome to then raise those. It doesn't need to be in the chat, it can just be here. You can equally switch on your video if you have any questions. The good news is, Chris, I do actually have a couple of questions. I just, listening to that, really good presentation, thank you. Just your own opinion, I appreciate, and potentially collectively the opinion. What do you consider at the moment to be the biggest issue within the care sector in terms of infection prevention control?
Staffing.
Staffing.
I think the care sector is in exactly the same boat as the health sector. We didn't have enough to start with, and they are leaving in their droves. Underpinning that, we don't pay enough. I don't think, and this is not a criticism now of the sector, this is the criticism of the broader system. It's also the personal opinion of Chris Patridge, I must stress that. I don't think we support them enough. I don't think we value them enough. I'm hopeful that the new structures of the integrated care systems, where we're all coming together into the same collective pot of a system in a locality, I'm hoping that will help, but I'm worried it's not going to help quick enough. We have almost them and us kind of barriers between different parts of the system, and social care and healthcare is the biggest barrier of all. We have to get over that. We have to learn to respect each other and trust each other much more. So it comes down to staff for me, and I see that Tina's put her hand up.
Yes. Tina, go ahead.
Hi, I've turned my video off because the sun is really blowing in the trees behind me, and I keep going light and dark. But no, I was just going to say about staffing. I work in a support to live at home facility, supporting a gentleman in his 40s. We used to be you couldn't even really call it a team. There used to be an awful lot of people coming into the home to support this gentleman. At one point in 1 month, about 3 years ago, we had 17 people in 1 month. So staffing wasn't an issue then. We then became a much smaller team with a few of us just dedicated to supporting this gentleman, and due to illness and injuries over the summer, we became a team of 3 offering 24-hour support. When there was annual leave, we became a team of 2, just tagging each other in and out, 24 hours on, 24 hours off. But the infection prevention has actually, in some ways, become much easier to manage as part of a small team, which is sort of kind of going against what you said, Chris. But at the same time, it's kind of been easier because you've had these long shifts to do all the infection and prevention and cleaning. So we've kind of given ourselves a pat on the back, even though we have been a really small team sort of over the last 3 months. We're all starting to feel a bit bleary-eyed now. But what you said about retaining staff, I can't echo enough, because we have literally sort of through just dedication to this gentleman ensured that he's had coverage for the last 3 months between just the three of us, and we're quite confident in our infection prevention. But we've got a couple of new members starting on our team next week, and we're actually all feeling a little bit anxious about, are things going to sort of remain the same? We've all been quite dedicated in our cleaning regimes, and it's a little bit concerning. And I didn't know if you really got any advice as to sort of how we can ensure that the newer members of staff sort of continue, I suppose, to our standards, which I think, because we've worked with this gentleman for such a long time, how we can sort of keep them up and sort of push forward. Does that make sense?
Yes, it does. Thank you very much for sharing that, Tina, and thank you and your colleagues for the devotion you have shown to your client. And I think there's a lot in there. There's something about control for me, and this is one of my favourite words, control, because that, with your reduced team, that makes you feel you have got that control. But I don't think we can rely purely on that dedication. You said you're all getting a bit bleary-eyed, you're all getting a bit tired. We're entering winter with respiratory viruses all over the place, and the diarrhea isn't far away from coming, and we're all a bit short on sunlight, and therefore our immune systems are a bit down. So I think, you know, we take advantage of people like you. We, the system, Tina, take advantage of people like you, and I'm quite happy to say I'm sorry about that, and I want it to change. Yeah, and I think also this is a very different setting from the care home setting, and I did touch briefly on this, it has a different set of risks. Yeah. It all comes back again. How are we supporting the staff? Shalina, I've seen your hand up. I think I'd like to go purely chronological, if I may, and answer Lisa, who's talking about my second favourite subject, which is the cleaning standards document. And this is, of course, a care home question, not domiciliary care. Yeah. Do I think that the standards are achievable? Yes, I do, but only if we are allowed to implement another wonderful word, pragmatism. The standards, whilst it says at the beginning they apply to social care, they clearly are written for a hospital where the risk is greater and different. If the standards are applied pragmatically to your situation, and you won't all be the same, then yes, I think they are achievable. Shalina, can I come to you now?
Hi, yeah. I'm Shalini, Quality Nurse Advisor. Shalini, yeah. I'm one of the Quality Nurse Advisor for Sandwell Place, and thank you so much. It was really a useful presentation. So the one of the challenges we face mostly, Chris, is you've already touched anyway with the staffing. That is the biggest thing as well. The other thing we come across is about the cleaning material. Some of the care homes, they use the cleaning material, and the contact time varies from material as well. So, you know, like the use of bleach and stuff like that. So before the contact time, they clean, and it's not very effective as it should be. So this is something we have picked up recently as well in some of the care homes, because they use different products that I'll just highlight to you.
Thank you. That's useful, and I think this does actually link very nicely to the cleaning standards, because if you do pragmatically implement the cleaning standards, that will include control over the cleaning products that you're using. I have fought supermarket bleach for the entire duration of my infection control life, because cleaners in care homes, in hospitals, in GP practices, wherever they are, they want to do the very best. And everybody thinks bleach is best. Well, of course it isn't. And as has been quite rightly said, contact time is important. So I think for everybody, have a good look at the cleaning standards and see how you can implement them sensibly, not replacing what you've already got. If it ain't broke, don't fix it. But just make sure you've got that level of control. And I think the other thing that it occurs to me is you're somebody, Shalini, that's going in and out of different care homes and you observe things. That makes you a very useful person. So how, my question now, I suppose, for care home people to think about is how you would feel if somebody said, actually, you know, I think you could possibly do this differently and it might be better. Would you feel threatened, or would you say, thank you very much? I don't know. I don't have to answer that question to me now, but perhaps have a think about it. That we can have that kind of monitoring help can come from the formal audit programs, and it can come from any Tom, Dick and Harry who walks into your home. Sometimes what they're saying might be rubbish, but not always. Okay, any more?
Any more questions from our audience? I do have a couple more, Chris, just in case. Okay. Interestingly, somebody has talked about the cleaning standards and obviously the introduction of that. Can you kind of very briefly give us an outline of when that comes into effect, where and when providers are expecting to implement them, or is that information not yet available?
It's not available, and it depends very much on who you ask. When it came out, there were some clear guidelines given on the timescales, but then that was withdrawn for social care, and it was made very clear that no, the timescales don't apply to social care. I've heard one or two people say the whole thing doesn't apply to social care, and yet it clearly states at the beginning of the document in the introduction that it does. I think it was issued in a hurry. It was issued as a bit of a response, knee-jerk response to COVID. And I think care homes, social care were dragged into it as a bit of a knee-jerk response. And I think the opportunity is there for care sector colleagues to get a grip of it themselves and say, this is what we are doing with it, because this is what is going to work in our setting. You know your settings. You know what will work and what won't work. I was made aware of one organisation that had just produced thousands of pages of policies and schedules and this, that and the other thing, which was a huge amount of work, cost a fortune and precious staff time, and was not what's needed at all. It has to be pragmatic, it has to work. And it comes down to, I've gone on and on and on about control, and there's a second word I put with it, and that's grip. Have you got grip and control of cleaning? So if you've got processes, you can call them schedules or checklists, it really doesn't matter. Do you know that everything in that resident's bedroom is clean? And how do you know? Then you can all sleep better and you will be compliant with the standards. That's my view. But we still watch this space on those cleaning standards. I've chased the original authors for a bit more guidance on social care, and they haven't responded.
No, absolutely. And I've seen the draft, and I can see why some people are a little bit nervous and a little bit confused. So, yeah, we'll as you say, watch this.
This is not a sales pitch, but we have, as a company, produced manuals. The draft you've seen, it's been amended quite a lot since then, Brett, and thank you for your input, to try and make it more user-friendly, bearing in mind that you can't say every care home is the same, because it isn't. No. But that, you know, that's a possibility. But you can do it yourselves if you just, as I say, shave out some precious time, really, to look at it.
Thank you, Chris. And then I have one last question, which I'm sure everybody will benefit from the answer. So obviously we've talked about support, information and resources. Where do you suggest people go who don't have the luxury of infection prevention control specialists at hand, so on and so forth, where they can find the relevant information, not just for care homes, but obviously for their particular care setting? And I appreciate that the guidance is not necessarily going to be specific, but maybe specific to a particular type of setting. Where's the best place for them to go?
So there is a National Infection Control Manual now. If you Google search National Infection Control Manual, you'll find it. Primarily, of course, produced for healthcare, but has a huge amount of relevance to social care. And that is only maintained electronically. So you know, if you go for the electronic version, it's the current version, because as soon as they update it, they remove the old one. So there's that. What used to be Public Health England is now called UKHSI. They provide a health protection advisory service that you can contact. And I think over time, through the ICSs, I hope very much that there will be much better infection control support. Within the ICSs, within the health side of it, historically, there's quite a lot of specialist advice. And because the ICS pulls everything together, health and care, then it seems perfectly sensible to me that that specialist advice would be there for our care sector colleagues as well. And if I can just go back to the cleaning standards a moment, their relevance to care homes is one thing, their relevance to domiciliary care is another. Because as a domiciliary care provider, you're not in control of the environment. So I wouldn't, to be honest, do a great deal of work with it at the moment.
I guess, and just on that, Chris, I would imagine that the focus is really around the infection prevention control for the member of staff, the employee, as you say, because the environment is very difficult to adapt in order for it to work conclusively for infection prevention control purposes.
And district nurses face the same challenges when they're sometimes undertaking some quite complex clinical procedures in a very difficult environment, you know, with cat hair and dog hair all over the place, and you've got a nasty wound to dress. It's difficult, and they have to adapt what they're doing to accommodate that.
Absolutely, absolutely. Okay, well, as obviously you can tell, we are coming to the end of this webinar. Just a last opportunity if anybody wants to ask any questions. Thank you, Lisa, for that additional piece of information that you put in the chat. For those that haven't seen it, it's the website infectionpreventioncontrol.co.uk, where you can get some more information. And I'm sure that if you contact Infection Prevention Solutions, that they would equally be able to assist you as appropriate moving forward. So I don't see any hands raised or any more questions. So I would certainly like to take opportunity to say thank you, Chris. That was excellent, very informative, and I hope that everybody else enjoyed it. Just to wrap up with a couple of dates for diary, as we normally do, we have our next conversation and catch up on Tuesday, the 1st of November at 10:30. That's an opportunity. We usually have a couple of key subjects that we talk about, but it also is an opportunity for yourselves to network with other providers in a similar boat, ask questions and understand their challenges as well. And then on the 8th of November, we have the fire safety webinar from Globex Europe Limited, and that's to talk about personal emergency evacuation plans and the management of those, which I'm sure lots of people will be interested in that one as well. And then we have the London Networker with DAC Beechcroft, and that is around investigation and a legal update. That will be on the 1st of December in their London offices. All the information I've just given you is available via our website, which for those of you who haven't visited it or new, fancy, very modernised, nice and easy to navigate, and that's at nashics.org. And of course, if you're not already following us on LinkedIn, if you just search for Nashix, and we talk about and highlight all of our events. All the events that I've just spoken about, again, are free. It's just a case of booking, and obviously once you're booked on there, you will receive the recording and the presentations given, as you will for this particular presentation. So once again, a huge thank you, Chris. That was really, really good. Thoroughly enjoyed it. Hope you all did, and have an excellent rest of the day, rest of the week, and stay safe. Thank you.